Good evening, everybody. So today I'll be talking about the role of radiotherapy in salivary gland tumors. I have nothing to disclose. So till now we have learned these are really rare cancers. And the salivary gland, which has the highest incidence of malignancy, the highest incidence of tumor, they have the least incidence of malignancy. So Dr. Neha has already shown the variety of the histologic variants we have for the salivary gland tumors, and all this makes the management really challenging because of the histology, biologic behavior, limited clinical data, and the decision for the optimal treatment is really challenging. It should be best decided in the context of multidisciplinary tumor board, considering the tumor extent, the site, the patient's comorbid conditions, and the support system. So generally the management consists of the surgery followed by adjuvant radiotherapy whenever indicated. So coming straight to the role of radiotherapy, it is indicated in different sites. It's like post-op radiotherapy, definitive radiotherapy, palliative, or in the recurrent cancers. So do we really have any evidence for radiotherapy? To remind you that traditionally the salivary gland tumors are considered to be radioresistance tumors. So there is no randomized trial. So whatever data is there from the retrospective series. So coming to, is there any role of radiotherapy in benign salivary gland tumors? This is a paper by Alan Chain, who has actually, there is a lot of papers, he has done a lot of work on the salivary gland tumors. So here they have included the patients, 25% of the patients at first recurrence and 75 at second or more recurrence, they received radiation, and the period of follow-up is really long, 17.6 years, and the 20-year actuarial local control with adjuvant RT in recurrent pleomorphic adenoma is 94%, which is higher than surgery alone, even at the first and second recurrence. To support it, there is a systematic review which have included 8 studies with 66 participants, and they also concluded that adjuvant radiotherapy reduces the recurrent rates. Now coming to the role of evidence for adjuvant radiation in the adenoid cystic carcinoma, this needs a specific mention. This is a large national cancer database study in which the patients, 73.6% patients received adjuvant radiotherapy. Overall, in the whole cohort, there is a benefit of adjuvant radiotherapy, as well as specifically in case of the positive margins. And special mention is that post-op adjuvant radiotherapy was beneficial in all stages of adenoid cystic carcinoma. So now coming to the other salivary gland tumors. So this paper by Chris Therad, it is gives answer to actually many questions. So this is a large series of 538 patients. They showed that there is an improvement of 10-year local control over surgery alone in specific histologic characteristics like T3, T4 tumors in case of closed resection margins, incomplete resection, bone invasion, and perineural invasion. So they give an indication, the set of indication where adjuvant RT can be used. So it also showed that there is an improved locoregional control when there is a node positive neck, and also the dose response relationship they have established specifically in the definitive radiotherapy setting. So there was a clear dose response relationship when the doses are 66 to 70 gray. However, the local control was really not affected between the interval between the surgery and adjuvant RT. It's not similar to the squamous cell carcinoma of head and neck. However, maximum up to 8 weeks should be considered. So they concluded that adjuvant radiotherapy to at least dose of 60 gray is indicated in T3, T4 tumors, incomplete or closed resection, bone invasion, PNI, node positive, and at least 66 gray to be given to unresectable tumors. This is all supported by, this is a last year database study, and this is another national cancer database study which show that the use of adjuvant RT lead to an improvement of the survival. So what about the early stage salivary gland cancers? So this is a recently published in Head Neck 2022, which they have included only major salivary gland cancers, early stage, and they have showed that there is no difference in the local control or disease-specific survival, even in presence of the high-risk histopathological features. So this is a beautiful study. Actually, they have tried to develop a prediction model to estimate the impact of post-op radiotherapy on survival. So there was 18,400 patients, and all major salivary gland tumors, and they showed that post of radiotherapy was improvement in the survival in T3, T4 high grade and margin positive cases. Also, there are other factors which were affecting survival as age, sex, the comorbidity index, and the other site of tumor. So based on that, they developed a model. This is available online, although it is not externally validated, but it is a beautiful one. You can try with putting the histological characteristics and now see how the survival is going to be. And they have shown that the patients with higher risk score, they have a poor survival compared to a low risk score. So coming to the elective neck treatment, so it is generally considered for adenoid cystic carcinoma in high-grade cases, invasive carcinoma, and explomorphic adenoma, and high-grade adenocarcinoma, salivary duct carcinoma, and high-grade acinic cell carcinoma. Here you can see everywhere the mention is high-grade. Dr. Neha has already emphasized on the importance of the grade and stage of the disease. So what is the evidence? This is again by same group by Alan Chain, who have actually given a beautiful, this is a beautifully analyzed study. So this is a retrospective series again, and clinically N0 neck and no neck dissection has been done. 52% had received elective nodal irradiation to a dose of 50 gray to the level 2 to 4. So the most common site of nodal recurrence was level 1 and 2 for the entire group. There was no contralateral neck recurrence, and it was not different for major and minor salivary glands. So they again demonstrated that the nodal failure, this is basically a function of stage and the histology. So when elective nodal irradiation is given, so the 10-year nodal relapse is 0% with elective nodal irradiation versus 26% without. So they concluded that elective nodal irradiation prevents nodal relapse should be considered in patients with high risk of regional failure. So whether to give nodal radiation or nodal dissection, actually this study says there is no difference. However, a combination of both lead to a lower locoregional recurrence despite the factor that these groups are the poor prognostic factors. So to summarize from this, so indications are specifically in benign tumors. It is a recurrent pleomorphic adenoma. In malignant, if it is a positive or close margin. In large tumors, in the high-grade tumors, involvement of the skin, bone, and nerve. And if it is infiltrating in the soft tissue, which is again, it's comes in the case, lymph node metastasis, and in case of the gross residual disease. So coming to some nitty-gritties of the radiotherapy, the target volume delineation specifically requires preoperative imaging, operative notes, pathology reports, and postoperative imaging, including the CT simulation. And there is a special consideration for the radiation oncologist when there is a presence of perineural invasion, which is very important factor for the locoregional control. The nerve pathway to the entire skull base should be delineated. So we have UK COSTAR guidelines, which gives the guideline how to delineate at different levels. This is at the superior level. This is at the external auditory canal level. This is at the mastoid air cells level. This is at the stylomastoid foramen level. And this is at the angle of mandible level. So these are the steps of planning. First, pre-planning, consent, counseling, simulation, contouring, planning, evaluation, and implementation. So I'll not go into the entire details, just to highlight what is being done. So generally for salivary gland tumors, especially for the parotid tumors, the patient is simulated in a supine position with face turned to one side. This is specifically used when photon and electron combination is being used. So nowadays, most of the times we are treating with IMRT. So hence you really do not need to do that. It is in the supine position with a 4-clamp of it. So these are the different plannings I can show you here. This is the conventional planning, which is a direct field. Here you can see the underdosing of the target volume, and there is a lot of low dose areas around the normal tissue. And then with the waste pair portal, the coverage became improved. However, the dose field is higher. Then with the moving toward the 3D CRT technique, there was a much better sparing of the normal tissue and a better target coverage. But again, there was a spill of the dose to the normal tissue. Now coming to the IMRT, this is one of the case of adenoid cystic carcinoma. This was a huge tumor with of size of about 7 to 8 centimeter, if I correctly remember. So here we have, this is the red one shows the high risk volume, and the cyan color, it shows the low risk volume PTV. And this is the kind of dose distribution we obtained with IMRT, and this is the dose volume histogram. So generally for parotid tumors, and all the salivary gland tumors, we generally consider IMRT as the technique of choice with aim of reducing the toxicity, especially. So coming to the role of particle therapy, in the current era, there is a lot of talk about the particle therapy, and as we are going to have our proton therapy, so we should be knowing about that. So coming to the proton therapy in the salivary gland cancer, so again, I need to mention that there is no comparative studies with the IMRT. So it is very difficult to draw the conclusion. However, for this, in this study, this is one of the last studies with 88% patients received post of RT. So what I want you to look here is that if you look at here the chronic toxicity or the late long-term toxicity, there is no grade 3 toxicity. There may not be any difference in the overall survival, but the toxicity is definitely decreased. So this is probably the only randomized trial for the particle therapy where the neutron therapy was compared with the proton and electron combination. This is really old study, 1993, and this study was actually stopped early. So these studies showed there is a significant improvement of the local failure rate. You can see the protons, they have a higher failure compared to the neutrons. However, there is no difference in the overall survival. But the neutrons, in the neutron arm, there was a higher distant failure. Probably that had led to no difference in the survival. So those, and one of the important factors for the neutron was the higher toxicity rate. However, this is a long-term result which shows that though severe morbidity was higher, that was not life-threatening. So regarding concurrent chemo, I think the next speaker is going to talk about it. The RTOG 1008 is going to probably answer about the role of this. So coming to the toxicities, the short-term toxicities is the skin erythema, mucositis, dysphagia, desquamation that we all know. For this is similar to the head and neck, all head and neck cancers, but which needs specific mention is the trismus, chronic otitis, and hearing loss, and the osteomastoiditis. So there is a poster, the study which has compared IMRT with the conventional technique for cochlear sparing, and it has been possible, though there was not much difference in the hearing loss, but however it was easier to spare the cochlea. So coming to the recommendation, Dr. Siva has already shown, this is a beautiful paper which has shown the different recommendations for surgery, radiation therapy, and chemotherapy. This is the different recommendations. You can go through it. And there is similar recommendation from Eurocan, which is a network of rare solid cancers. They have also given the similar kind of recommendation. And to summarize, so the adjuvant radiotherapy is specifically indicated in the intermediate high-grade tumor, T3, T4 stage tumor in case of PNI positive, close or margin positive cases, and the lymph node metastasis. ENI is again higher grade and higher stage tumor. The importance has been already so many times emphasized by Dr. Neha in her presentation. So the volume of elective nodal irradiation is generally confined to level 1B to level 3 because that is the most common site of failure. So definitive radiotherapy is indicated. The doses are higher for the residual disease, and it is a recurrent and unresectable tumor. And for the technique, the IMRT should be the preferred technique of choice. There is no indications of particle radiotherapy as of now. So if you coming to the dose, the post-op radiotherapy dose is 60 to 64 gray, and the radical doses are 66 to 70 gray, and the elective doses are 50 to 25 gray. Though this is a blanket radiation therapy technique, however, there has been coming up with a lot of molecular targets, and everything is happening. Probably the prognosis is going to be established for different. We really do not know how it is going to be in future for radiotherapy, but probably it is really going to change, and one size is not going to fit all. So thank you very much. Thank you, organizers, and I would like to thank the entire team of radiation oncology. Thank you. If there are any questions, I'm happy to take.
It's a great talk, man. One question is there in chat box. How to go for a patient having high-grade tumors with contralateral neck mets? He's completed NSCT and referred with PET, which is showing CR at the parotid, but having a contralateral mets.
Patient with contralateral neck mets?
Yes, ma'am. He is a CA parotid with contralateral mets. Initially, he received NSCT, and then they did surgery, and then they did a PET. Now he is that contralateral mets was not addressed while doing surgery. He's asking for how to plan this case with what dose we can plan and what is the dose value.
So I am really surprised if the patient had initially contralateral nodal mets, the contralateral neck should have been addressed. So if it has not been addressed, and if there is a complete response, so for the ipsilateral side, I assume that surgery has been done and neck dissection has been done.
Yes, ma'am.
Is
Yes.
it so? So ipsilateral side, it should be considered like the post-op radiotherapy doses like 60 gray to the involved levels. So he has to go back and see what are the nodal levels involved. Because following NSCT, if there is a real response, so then we have to consider like the previous pre-NSCT levels of nodal involvement. Accordingly, the dose has to be tailored. The involved levels should receive at least 60 gray, and the elective nodal level on the same side should receive at least 50 gray. For the contralateral neck, if as it is not been addressed, I would suggest to go ahead with the radical doses up to 70 gray, and the contralateral rest of the elective nodal levels to the 50 gray at least.